Thanks, Philip. It's quite difficult to follow that. It's hard not to get emotional. I want to take you back in time, 21 years as it happens, on a crisp autumn morning in Pretoria. Those of you who know Pretoria would know it's what we call the Highveld, so it's on a plateau, it's slightly elevated, well, more than slightly, it's 1,300 meters above sea level, roughly. So autumn is an interesting time. It's crisp, sky is clear and blue, the trees turn, there's sometimes a little bit of a breath that you can see when you're breathing in the mornings, you know, that really crisp air. It was one of those mornings, and this was, of course, the time before cell phones. So my pager went off, and I rushed to the hospital because I was called there for an emergency. And as I walked into the high care unit, is what we called them in those days, high dependence unit or post-operative care unit, whatever you want to call them, I walked in and I saw a guy in front of me standing on his hospital bed, eating his plaster cast off his arm and ramming his foot into the bed. And you can imagine the shock. That is such a vivid memory. Now, I need to take you a couple of days back before that to give you the context. This guy was the first patient on whom I've done an Ilizarov frame. This was done in 2003. He was a polytrauma patient. He was a repeat offender. He used to walk in front of trucks all the time. So this was his third injury or something. He had an upper limb injury, can't remember the details now, but he also had a shattered plateau. I don't think the Schatzker classification goes as far as what this guy's tibia was like. I think it's a Schatzker 300 or something. So this is the guy. He had what we always use is a tattoo to teeth ratio. He had more tattoos than teeth. That's always a bad sign. He was my first patient, so I applied the frame on him, and we put him in the high care unit, very proud of ourselves, and the next couple of days he started withdrawing because he was, of course, an alcoholic. And that is when I found him standing on the bed, eating his plaster cast, banging his foot on the floor. What struck me from that is a couple of things. The one thing is that the classification for madness doesn't encompass this form of patient. It doesn't exist in the DSM classification. The second thing is the incredible weight-bearing ability of an Ilizarov frame, even though it was applied by somebody for their first time, and actually by somebody who didn't know at all what he was doing, and yet the fracture survived. The patient went on to heal. We gave him some anti-madness medication, small little bottle of Jack Daniels, and he stabilized, and he went home. And that was where my journey in limb reconstruction started, with that index case. It actually started a little bit before that. At that time in our training hospitals, we were often supported by really good consultants in our elective surgery side, but unfortunately on the trauma side, we often were left a little bit to our own devices. Now, that was not necessarily a bad thing because we were sort of forced to learn and to make it up and to read and to apply techniques. But what became very clear to me very early on, and at that time I was working with Len Murray very often in the trauma firms. For some reason, we were always rotated into the trauma firms, and we were always rotated there together. So we started seeing these patients for whom we didn't have classic orthopedic answers. Bone defects, bone infections, bad periarticular fractures, non-unions. And we started thinking, how can we improve these patients' lives? And that's when I stumbled across the concept of the Ilizarov method and the devices that go with that. And there was an old dusty book in the university library, the original Trans-Osseous Osteosynthesis book from Ilizarov, which was translated by Stuart Green. And there was also the book by De Bastiani about distraction osteogenesis and the application of his techniques. And those two books really were the backbone of my fellowship training for limb reconstruction. I read both of those cover to cover. Eventually the library phoned me and said, well, they need the books back at some point because we cannot register you as a student if you don't bring those books back at some point. So I really absorbed this concept, and it became such an internal thing for me. It became a passion almost from the outset. It just ignited something in me in a very similar way that when we do the osteotomy and we start distracting, it ignites something in the bone. And this is what happened inside me with the concept of distraction osteogenesis. Of course, we then started treating our patients one by one. We started identifying suitable patients, and we started doing them. And at this time, I was still a resident. I was, in fact, still in the earlier part of my residency. I actually only finished my residency in 2006. So this early part, 2003 to 2006, I was really honored to be able to do this work in an environment where it would normally not be done. Our professor at the time, Professor Klaus Maritz, was really a visionary in that respect, and he was a fantastically interesting individual. He had a really interesting hairstyle. He was a menace in an exam, but he had this mechanism to develop people. And he saw things in people, and he actually brought the best out of them. And he was instrumental in providing me the safety as a registrar to actually do this work. So he created a bubble around me so that I can continue with this work. Because back then, as Philip alluded to, rings were the devil. In many places in the world, that's still the narrative. Non-union machines, expensive devices, patients will never walk. In my practice, a ring will never work, but the patients will never accept them. These are the narratives we keep hearing. And that was true at that time. There were only a handful of people that were doing Ilizarov frames at that time, and it was mostly in our pediatric orthopedic community. Mark Eltringham, Professor Einhard Erken, these are the guys that were sort of the pioneers in the Ilizarov method in South Africa. And Hans Pretorius is another one that comes to mind. So that was the backdrop. And against that backdrop, Prof. Maritz allowed me to start a limb reconstruction unit as a resident, which was really strange and weird and intimidating and scary. But once a week, I would go on a Monday afternoon, and I would go and do my clinic. And a week later, I would do the surgery, and a week later, I would do the clinic again. And that's how a 2-weekly interval of follow-ups became established in my practice. So every patient gets seen every 2 weeks. And it wasn't some magical thing, it was just that I happened to have a clinic every 2 weeks. And that's how my pattern got established for a 2-weekly follow-up. I can vividly remember sitting on a Friday afternoon in the theater complex, alone, apart from the guy that was on call. We were the only 2 people there. I would religiously pre-build and pre-plan my frames, sitting there, putting the screws together, rebuilding the frames for the Monday's theater list. It was an interesting time, and during that time, we started seeing more and more bone infections, bone defects, complex fractures, and eventually had some of those referred to us by the other firms and the other disciplines in our department. So I think during this narrative that I'm going to give you, I also want to share some, call it pearls of wisdom. Use it, don't use it, it's up to you. The first one is grow where you are planted. So make sure that there where you are, you start growing and you start making a difference. Don't wait for that magical, someday I'll be in this place and then I can start growing. Grow where you are. That's where you establish your excellence. After that first couple of cases, I was invited by Mark Eltringham to become part of the, or become the other half of the Ilizarov course faculty. We had in 2003 the first meeting and 2004 the next one. And that was really where ring fixation education was skyrocketed in our country. Mark had just returned from Baltimore, and we started creating a sort of a deformity course for South Africa. And that grew over the years and expanded into multiple courses and multiple platforms. But that is where a lot of it started. During that period of 2004 and 2006, I was also quite honored or privileged to be invited to attend a meeting in Manchester that was hosted by the British Limb Reconstruction Society. And that sort of opened my eyes to what was going on elsewhere in the world, because suddenly there were other crazy people that were doing this stuff. It wasn't just me. Suddenly I could see, but there's a guy in Liverpool who also does this. There's a guy in Newcastle who also does this. There's a guy in Hull that also does this. So my craziness is not my own, it's actually shared. So I'm not the only Lord of the Rings out there. That got me in contact with a very interesting individual and a very big mentor for me, Duray Nayagam. Those of you who know him would attest to the fact that he's probably one of the biggest gentlemen in orthopedics, but also one of the biggest minds in orthopedics. He's really a guy that can take a really complex problem and simplify it and explain it in a way that even stupid people like me can understand. And I went and spent only 2 weeks with him, but those 2 weeks were incredibly formative. Yeah, that was like a condensed fellowship all in one, and that really changed my trajectory massively. So as an influence on my journey in limb reconstruction, that was the first really big one. I also went to the Baltimore deformity course in that bracket of time, around 2005, if I remember correctly, and in that time got exposed to all the detailed deformity analysis and planning, and there was a group of us by that time that were interested, and we went together, and I believe Sean, we were there together. Where's Sean? Not in that trip, or were we?
I've still got pictures of you of that trip.
Yeah, eating crab. Yeah, so that was amazing. So at that time, we started developing a little community of surgeons that were like-minded, more Lords of the Rings around the country that started getting involved in this stuff. And it was interesting to expose ourselves to other places. Also, at that time, I was invited to go and visit Verona, where Orthofix is based. And that opened my mind again in a slightly different direction. At that time, the Sheffield ring fixator was the ring fixator that was available in Verona. In South Africa, we had only really used it for trauma as a sort of a hybrid fixator. But there I saw how this fixator could be used with hinges, with distractors, and we could start doing bone transport, lengthenings, deformity corrections, and that really opened my eyes to the possibilities there. Another interesting thing that happened during that time was the fact that I did my first hexapod fixator at the end of 2004, beginning of 2005, in the form of the TSF. Continued perfecting my craft by doing case after case, doing different pathologies, building the frames on Friday afternoons. What was interesting when I look back is two things that stand out from that period of time. The one is, it was actually the time when I deployed my first 3D printed foot model for pre-op planning in 2006. You can imagine what the technology looked like at that time. It was really very weird to print things at that time. I found a funny engineer in a strange building somewhere in the back of the industrial area in Pretoria, and he was prepared to do 3D printing for us. And we printed a 3D model. We just got time to get it to theater to apply the frame and to visualize when it fell apart because it crumbled into powder. But that was the first 3D printed model we did in 2006. Also at that time, we meddled in electronic health records, something that didn't exist at that time. So we got a software developer to develop a software package for us for our limb reconstruction unit. Was fantastic, worked for about 2 weeks, then crashed, and the guy disappeared with all my money. And to this day, that software doesn't exist anymore. So the second point that I want to share with you, if this works, is innovate constantly. So constantly push the boundaries, constantly innovate, constantly advance your skills, constantly grow. That is such an important part of limb reconstruction. During that time, I was fortunate to complete 100 frames, give or take, by the time I finished as a resident. So I had those 100 frames in my pocket when I exited as an orthopedic consultant. I was lucky to be able to be on the Traveling Fellowship, which is an annual event that is sponsored by one of our local companies, and it invites a group of final year students, registrars, tour around the country, share their research with the rest of us, and I was probably the first and the last person who gave lectures on circular external fixation during a time when it was not accepted at all. You can imagine, those of you who know Robbie or knew Robbie Snowden, you can imagine how that went down. He was a notoriously aggressive and difficult head of a department in Bloemfontein, where they absolutely didn't like external fixation at all. And I can't repeat the words he used, but he was not very happy that I would present on that topic in his academic meeting. I remember him sitting in the corner, actually smoking during the meeting, and just putting his head in his hands. And anyway. So the third point that I want to share with you: push your limits. Push the limits both internally and externally. So it doesn't really matter how difficult it is, push through that limit. It's really important. Another thing that comes to mind during that time is for my final exit operation that we had to operate to get our degree, I performed a segmental bone transport. Most people did a trapezium excision or a carpal tunnel. Some of them were brave and they did a bunion. I was stupid. I chose a segmental bone defect in the tibia and I put an LRS frame on that. You can imagine how that went down. That was quite a lot of fun. In fact, Len Maria assisted me for that procedure, and I can vividly remember actually sticking him with a scalpel by accident because I was so nervous. And he actually hid it from the examiners quite effectively. So they didn't see that happen. And because you can imagine what that examination would have looked like from there. Then we would talk about needle stick injuries, post-exposure prophylaxis, HIV prophylaxis, blah, 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 which I knew nothing about. So I must actually phone Len tonight and just thank him for that. Because he actually was instrumental in me passing that examination, I'm sure. He does. So it's true. That was an interesting transition time for me from there, because that was the time when I then finished as a consultant. And there was a transition time where I was able to continue running the limb reconstruction unit at the academic hospital. But I was recruited, is probably the right word, into a private hospital at that time by the name of Unitas, which is at that time was sort of a level 1 trauma center with a helicopter based at the hospital, really busy trauma unit. It's still a very big and busy hospital. And the guys there needed a trauma surgeon. So I actually then bowed to the private gods and went out into private practice, and very soon realized that if I wanted to look after my patients, both private and public, I needed to make a choice. I couldn't stay in both. And at that point, because of a lot of reasons, I was not able to secure a permanent post at the hospital, so I decided to go into private practice. And that's where my journey started as a reluctant private academic. And that I've been that ever since. So I am lucky to have a real interest in academic medicine. I am unlucky to work in an environment where that's not really supported. And I have to find a balance between this. And that's been a constant struggle for me throughout my career. Sorry, I don't mean this lecture to sound very self-promoting. If it does, I really apologize, but it is about my career, so that's why there's a lot of I's in these sentences. So please, it's not the intention. So these guys will cut me down to size very quickly anyway. So so that was an interesting period between 2006 and 2010, because that was really sort of, in my mind, my golden period, if you will, where I really did a massive amount of cases. It was not unheard of at that time to be on call for a weekend and do 24 trauma cases over the weekend, of which 3 or 4 would be polytraumas, and they would fill up your theater list for the rest of the week. So during that time, I was constantly doing 8 frames per week, every week, 50 weeks a year. So that built up my confidence quite quickly. It built up my reputation quite quickly. It also built up my complication rates quite quickly. And it was an interesting time to be able to expand my knowledge, my skills, and deploy all these complex things that I learned over the years into the private patient population. During this time, I was also very active in education and expanding education in circular external fixation. As you've realized, that is a big passion of mine, is to educate. And we felt that it's really important to lift the quality of limb reconstruction in the country. And we were lucky to be able to host hospital-based observerships at my hospital and start them up during that time. During that time was also the time when I first saw the TrueLock fixator. I met these Russians as faculty. I was a delegate in Verona. They don't remember it, they wouldn't. I was a small non-compete. You might remember, I never asked you this, you might remember there was a table at one of your workshops, you might not, where we did an equinus correction with a TrueLock frame, and some crazy guys from South Africa put wheels on the TrueLock fixator. We were on the front table on the left. You remember that? You don't. You do. Yeah. So that was us. So that was my first exposure to the TrueLock system, and shortly thereafter I did my first TrueLock Plus case. This must have been in 2008 or somewhere. Fritz, when was that? Can you remember? First TrueLock. I just remember vividly we didn't have enough nuts on the set. Fritz came from the Sheffield background and the LRS background where they don't really use nuts, or use a few. So we were doing the case, and I was saying nut, nut, and I saw him go white, nut, nut, and then he went red, nut, nut. Eventually he was opening all the sets, and from all the little components he would take nuts and bolts so that we can finish the case. It was quite interesting. During that time, I also started developing our multidisciplinary team and starting to see the benefit of having a good multidisciplinary team around you. One of those team members was the orthotist that I worked with, and during that time we then developed what is now known as the X-Gator track and X-Gator light devices. Might have come across them. These are the footplate things that we attach to the frames on occasion. So that was also an interesting new product that we created during that time. Let's see, what were my next points there? I think I'm getting ahead of my slides. Okay, so yeah, absorb and grow is one of the things. So try and learn from as many people as you can and try and become better at what you do. In that vein, we also visited the British Limb Reconstruction Society meeting in Newcastle in 2008, where I was asked to give an invited lecture on limb reconstruction in the third world. And that was quite an interesting experience for both sides of the podium, because I could share the volumes of work that we were doing, but also the realities of doing it in a resource-constrained environment. And then demonstrating how these techniques are actually best deployed in an environment like ours, because that's where they were devised. If you think about Kurgan, where Elizarov worked just after the Second World War, that was not a modern Western society. That was a society where people had to walk to fetch water. They might have go outside for a bathroom. So it was a very real representation of what a lot of our patients had to deal with. So that reality check was quite important for all of us. 2010 became a bit of a turning point. 2010 is when opportunity knocked on the door. 2010 is when these two guys, via Fritz, contacted me and said they want to talk to me about a possible hexapod fixator by Orthofix. And that's also the first year where we created this course. So 2010 was important because it was our World Cup year that we hosted. Who can forget Shakira in her skimpy outfits singing in front of the president? He was very sick at the time because she didn't get pregnant. He really must have been very sick at that time. Sorry, I shouldn't make political comments. Yeah, so 2010, let's come back to the point. 2010 was an important year. I met Mikael and Alex formally. We devised a strategy. They showed me a very exciting project, and we decided to go ahead and be involved in the project. So they asked us to advise on the hardware and on the software, and together with them, the project then was developed further, or it was developed by them with a little bit of help from me. And then the first limb reconstruction meeting started, and we gave it a lot of thought. We saw in the landscape we had a lot of courses. So we had deformity courses, we had basic circular external fixation courses, we had courses on pretty much everything in orthopedics. But what we didn't have was a place where we as limb reconstruction surgeons could come together annually and come and share our ideas, but also become a place of education. So it needed to have that aspect of education for somebody coming online for the first time, but also be a place where our more experienced surgeons can return to every year. And that's why it's also not called a course, it's called a meeting, because this is really what it is. It's a meeting where we come together, share ideas, and it becomes a platform that's much wider than pure education. 2012 was interesting. That's when we had our daughter, which was about 9 years after my son. So you can imagine how interesting that is just physiologically, waking up in the middle of the night 10 years later. That was quite difficult. But she was born a day or two before the first TL hex was applied in the world. And that first TL hex, Nando and myself did at Gray's Hospital. And I believe it was around the 13th of November 2012. Yeah. So, yeah, that was for a non-union case, close distraction, quite a cool case that we did together. It is published as a case report, and that's the first one that was done in the world. Actually, just purely because the patents didn't exist here. That's the opposing patents. But maybe we were slightly special too. I don't know. Shortly thereafter, we started using the TLX more and more, and a lot of the people in the group in the room actually have a lot of experience during that first phase where it just got launched, and we started using it, and we're very excited about the project and the product and how different it was from what we were used to. Because hardware, software was recognizable but different, and in our minds improved from what was available from the competitors at that time. And lots of cases got done. We hosted our first HPO with, HPO is a hospital-based observership, with TrueLock Hex in December of 2012, and Alex came out for that one, and he did his first TL Hex case on a patient with me during that HPO, and that was such a great honor, and it's still one of my favorite moments in my career, is that we shared that case together and did that big brown sky. Trevor, he still texts me regularly to thank me for, helping him during that time. 2012 was also interesting. It was when Precise was launched in South Africa, and we were also involved in the first case of Precise lengthening nail in the country. Right, so then 2012 was important. 2012 was important not because the world ended, because it actually didn't. It actually went on. It was quite underwhelming, actually. We were all expecting the world to end in 2012, right? The Mayans predicted the end of the world, and yeah, that didn't happen, so it's actually quite disappointing. So we had to continue. So I could only continue by bringing in a partner in crime, and that's when I and Philip started our journey together in 2012, and that lasted a full decade, essentially. One of the most valuable things I've ever done in my life was to actually bring Philip into the practice. That has skyrocketed my growth tremendously. It has given me the headspace and the partner in crime to share ideas, to grow ideas, and that was really important to realize that this is not a one-man show. This is not something that you can do alone. You can do it as a lone wolf, but it's much better to be in a pack. And you need to create that community around you that can support you, because this is not easy work to do. At that time, we established the Walker Mile Center for Orthopaedics in Pretoria, which was our practice's cool name. And we continued to create this team around us of experts to actually help us and support our patients. To just pack it all up and move cities to a completely different part of the country and just start a new practice. Why? I wish I could tell you. Midlife crises work like that. They don't really have reasons. It just happens. So I then translocated to Stellenbosch, where I am working at the moment. I'm now back as a lone wolf in a practice, so making the same mistake again. And, but I'm working in an institute where we have like-minded individuals around us, and we have actually a formalized academic program in the institute. And if you ask me what the real reason is why I moved, that is the real reason, because we can create that private academic environment a lot easier. So that was the transition, and that is where I am now. Now, milestones are really important in life, and milestones set you on a certain path. And I've shared with you some of these milestones during my career. So the Ilizarov in 2003, the crazy guy that danced on his frame, the TSF in 2004/5, TLX 2012, VSBs, HPOs, and the list goes on. Of all the things that I think I've changed over the time, you know, organic growth of this technique would have happened anyway. I don't think I was very instrumental in necessarily expanding the growth amongst other surgeons. But where I did make a difference is I engaged actively from the beginning in the private practice with the insurance companies. So I can remember vividly sitting with Discovery and Momentum and all these big insurers in boardroom tables, trying to convince them, trying to show them how these techniques are valuable. When I started in private practice, this was a completely unfunded technique. They didn't pay for it at all. And through tenacity, we were able to change that narrative. And it wasn't me alone, it was a group of us, but we were able to change that. And now the funders still hesitate, but they do pay. And that is a big thing that I'm really proud of, is that we were able to do that. On top of that, we engaged with the Department of Labor for the workmen's compensation patients, and we were able to start convincing them also that they should pay for this, and that it would be beneficial, because at that time they only paid a third of the external fixator price, because they said that you can reuse them and they can only afford a third of the price. And now they're actually funding it more fully. And then general acceptance, just not being that person on the outside, but actually making it a more commonplace way of treatment has been a real journey. During that time, we also set up the South African Limb Reconstruction Society, which still exists. It is a subsidiary of the Trauma Society, and I would encourage you to reach out if you want to become part of that. We have a membership, and you can, I think currently Nando is still the president, so we can reach out to Nando and find out about membership in that way. Other things that excited me during the time was product development, being on advisory boards for companies, helping them with products, fine-tuning products, making these products better for our patients' benefits. People are really important, and on my trajectory, the people that stand out are a longish list, and I will start with probably the two most important ones that set me on this path. The one is Professor Maritz, the head of the department at Pretoria, who created this environment for me to be able to grow, and Mark Eltringham, who actually introduced me to his first Ilizarov course, and then from there it grew. Duray Nayagam I've mentioned from Liverpool. He's been absolutely instrumental in my approach to patients, not only on the technical side of limb reconstruction, but also on the human side of how you should see patients and how you should see the problems in the context of the patient. Badri Narayan, which is an unsung hero in limb reconstruction in the UK. You probably haven't heard of him, and that's because he's incredibly humble. He is an absolute giant in limb reconstruction and a legend. He really is one of my big mentors in this game. Jim Binsky. Who's heard of Jim Binsky? Yeah. Jim Binsky was one of the most prolific TSF users in his time. He was a trauma surgeon in private practice. He was non-academic, and because of all of that, we hit it off pretty much immediately when we met, because we were kindred spirits. We were doing large volumes of cases, but we were not writing any papers. And that was an amazing time to actually spend time with him, teach with him, and learn from him. Towards the end, he couldn't walk anymore, but he could still operate like crazy. He was the only guy that I'm aware of that was allowed to do a TSF in the Ilizarov Center in Russia. And I think they did a competition to see who was the fastest, or I can't remember the details, but...
There are certain cases there.
Yeah.
But also, he was only one person who I know, he was doing 250 frames a year.
Yeah.
It's just
No, it's incredible. His workload was just... And he was doing it essentially alone. You know, he wasn't in a department or anything. He was basically doing it alone. Gavin de Kivet. Gavin de Kivet, who knows him, or who have heard of him, also one of these people that you probably won't hear about because he won't tell you about himself. A little bit unlike me, I guess. Gavin is also one of the biggest thinkers in orthopedics, and he's got a varied skill set. He's one of the few people that can take a Sufi apart and put it back together and the head survives. He's one of the few people that can really understand fundamentally a three-dimensional foot correction frame. And he can actually tell you the mathematics behind it too. Gavin is an incredibly gifted individual, and if you ever have the opportunity to meet him, spend that time, have a coffee with him, tap his brain for whatever you can, because he's an incredible individual. Hemant Sharma, over there. You can see his face, just as humble as the others. Hemant has rubbed off on me over the years, and his incredible ability to take complex problems and make them really, really simple, and then articulate that, has really resonated with me. We've become good friends over the years, and I've even been able to sneak in some wine into him occasionally. He doesn't usually drink except when he's around me, so I'm a really bad influence, I know. But Hemant, you've really made an instrumental difference in my life and in my career, so thank you. I really appreciate that from the bottom of my heart. Mike and Alex, I'll sort of separate you two a little bit. I know you're normally like a unit, but I'm going to separate you. Mike, for the trust you've placed in me to help you guys develop this baby of yours and to help walk this journey with you. And as actually the earmarked successor of Ilazarov, it was an absolute privilege over the years to be able to learn from you and to really get the truth behind the Ilazarov method, because there's a lot of myth out there. And it was so good to actually just see the thought processes, the basic science. I don't read Russian, so I can't go back to the original research, but you were able to show us what that means and where it actually comes from. Alex, probably one of the most fun guys I know. He's always evolving, he's always growing, he's always involved in the latest technology. You could see in his lectures, he's putting ChatGPT emojis in there. He's always showing us new ways to use the software, new ways to evolve the hardware. But personally, it's been absolutely incredible to see how you do that and how you build that into a busy clinical workflow and still balance that with life. And that's a beautiful thing to actually see. Rob Rosbrook, who's not here, he's been an influence on me from afar. He's doing a lot of similar things to what I'm doing. He's in New York, and we've sort of got to know each other over the years, and he's been an interesting influence. I can mention so many more, and I can mention pretty much all the faculty members in this room. Each of you have had an instrumental effect on me as a person. We don't spend time together without rubbing off on one another, and it's been absolutely incredible to see that happen over time, and the benefit I've gotten from that is incredible. And that's why that point is really important. Networks are really important, and you need to grow them, but you also need to look after them. And that's not for selfish reasons, it's actually to help your patients better. Okay, we're going to go into education a little bit, and we've already shared with you all the stuff that we've been involved in over the years, but I would like to, just by show of hands, who has been involved or attended one of my HPOs or visiting surgeons programs? Yeah, that's a decent amount of the room. And I want to thank you for that, because what you didn't realize is that I actually had an ulterior motive. So I realized that if I wanted to expand my knowledge and my skill set, I would need to go and visit experts. But I can't afford to go and visit experts because I need to treat patients. So how do I do that? I let them visit me. So I create a visiting surgeons program, and I import experts to me. I convince them that they're going to learn something, and then actually I'm the person who learns. And that was so fantastic. That is one of the best ideas I've ever had. Because over the years, that served us well in terms of development and actually improving our skill sets. That's something I use very often, is craft better surgeons. And the calculation is actually quite easy. Generally, if we're prolific, we do about 10 cases a week. That means we're doing about 500 cases a year. So that's the amount of impact you can have on patients. So if I do one course a year where I'm influencing 30 people, I can impact 15,000 patients. And if that spans over a course of 30 years, that's almost 500,000 patients that get touched by the impact I have on a patient. So as a calling or as a doctor that wants to have an impact on patients' lives, it's much more efficient to actually train surgeons than it is to be a surgeon. And that's the secret of why we do education, because it actually expands our influence drastically and helps as many patients as we can. I'm going to skip over that stuff. A couple of research highlights. I think it's very, very important when we're doing stuff that we also measure what we do. And a couple of highlights that I'd just like to share with you is we worked on amputation versus reconstruction. There's always been this narrative that an early amputation is better than a late amputation, and that we need to, sacrifice the limb early because, all of that narrative. And we've done study to show that that's actually not really true. Close distraction of non-unions, that's a technique that Nanda has really perfected. We've published on that. We've sort of looked at the mechanobiology of non-union distraction and how to heal them in more than 80% of cases without bone graft, without other interventions. PMMA spacers and how we use them in complex lower limb trauma, bone defects, infected, non-infected, and how they are used in something we call the Road to Union protocol, which is a very structured protocol to treat bone defects with cement spacers and then transport through that space. We've done work on gait and outcomes and looking at functional outcome measures and combining that or comparing that with gait analysis to see, and they actually correlate quite nicely in our frame patients. Forearm reconstruction, so bone defects in the forearm, non-unions, and how to reconstruct them separately from each other so that you maintain pro and supination. The use of the Ponseti Hex device, which is basically the Ponseti-Taylor type of device to correct complex three-dimensional foot frames. We've got a case report or two on those, specifically in the adult population, where we've done some work on that, and Ziad was instrumental in that with us. Bayonet closure of wounds, that was one of my other fellows where we do intentional shortening of the open fracture wound, get the wound together and distract afterwards. And then our series on precise nails. So really important to measure what you do and then share the results. The next one is complications. I'm actually not a limb reconstruction surgeon. I'm actually a complication surgeon because of all the complications that I've caused in my life. I've pretty much caused every single complication that you can think of, I've caused. Complications are a part of life. They're a part of what we do, and we need to embrace them. We don't need to necessarily enjoy causing them. We need to try and prevent them, but when they do occur, embrace them. And the reality is that without complications, we would not be limb reconstruction surgeons, because a lot of the patients we treat, we actually get as a result of complications. Hopefully not always our own, but we do see complicated cases coming our way. So embrace your complications, be honest about them, and be honest with your patients about them. So this very self-promoting talk is nearing the end, where I think I've shown you that I've been able to establish myself as a limb reconstruction surgeon over the course of the last 21 years. I still have a long way to go. I've established limb reconstruction as a field in orthopedics in South Africa together with all my partners in crime. We've been able to do that. It's become an acceptable thing to do now. We're not the outcasts anymore. I think we've established educational pathways, so a South African doctor that wants to train as a limb reconstruction surgeon doesn't need to leave South Africa. You can actually plug into our education system and actually become a really proficient limb reconstruction surgeon. In fact, many people around the world come here to come and learn how to do this, and that is something I'm personally very proud of. So the question is, what now? 21 years. Technically, I'm an adult now. Where do we go from here? Well, I'll share with you what we're busy with a little bit. And some of that stuff, let me just get there, so don't stop, so continue. Some of that stuff, we've just started the 3D print lab, or a 3D lab, not the 3D print lab, a 3D lab at our hospital. We're busy with research in machine learning and data science, looking at regenerate failure. We're busy with augmented reality solutions where you can put on a headset and it will navigate you through a surgery. We're looking at new devices that can improve the lives of our patients. We're at the cusp of deploying our academic unit where we will have fellowship programs and registrar rotations through our private hospital for orthopedic surgeons. We're meddling in the area of osseointegration, bone-anchored prosthesis limb replacement, which is a fantastic technology that we are hoping to bring to the country within the next year. It's already here. Nando has done the first case. We're hoping to open up the door to bring in more cases, but in a responsible way. We will continue doing what we're doing. There's a saying that before enlightenment, you fetch water and you chop wood. After enlightenment, you fetch water and you chop wood. So what that really means is you just keep doing what you're doing, and somewhere along the way, you will reach enlightenment. I hope it doesn't take me another 21 years, though. I would like to recap the learning points that I shared with you. But before we do that, that's probably the most important one. The small things are actually the big things. And what I mean with that is both professionally, so attention to detail, looking at meticulous planning, all of that stuff, that fuzzy stuff that we talk about, that's really important. But even more important, sitting down to watch the sunrise with your loved ones, listening to your kid complaining about something at school, your dog wanting to cuddle up with you for the night. Those are actually the big things and not the small things. And we must always remember that. As doctors, I've seen so many of our colleagues lose the way because they don't focus on this stuff. This is really, really important. And if I can leave one message with you, it's this: the small things are the big things. So there's your learning points. If you want to use them, don't use them, whatever. Maybe it's just the ramblings of an old man, I don't know. My message to you is my journey is only getting started. How about yours? Thank you.